but they chose to describe it as niacin linked, and they didn't do a single niacin experiment in the whole study. It was just a metabolite that was up that is distantly associated with vitamin B3, or I mean, even tryptophan is in that pathway. And so we had to correct that, and because that to say that niacin has a bad effect on cardiovascular disease is deadly, if you will, deadly wrong. And so we carried on describing how, in fact, it's been shown that, for example, there's a massive 11% reduction in mortality in a Veterans Administration hospital analysis, looking at 3 million patients over 8 years, and it's got a really low p-value after niacin treatment. And perhaps the best clinical trials outcome ever for cardiovascular disease was probably, to my awareness, the coronary drug project in the 1970s, where over 0.5 gram of immediate release niacin was given, and they got an 11% reduction evident even 9 years after cessation of taking the drug. And just there's a bunch of other statistics with that are just incredible, but they've always tried to come up with something different to remove the flush or do extended release or sustained release niacins, just something different because you can't patent that. So there's that whole history. And it turns out, you know, Abram Hoffer, he's probably treated more people with niacin than anybody in history. And his favorite was niacin, not niacinamide. And so I think a lot of people in the orthomolecular community have kind of been aware of that. So we wrote about that, and then, yeah, so.
Yeah, hey, Stephen, anything to add? Stephen is also a co-author of that paper, of the great paper. We all learned a lot. Good morning.
I like to thank Todd. We hadn't met up until, what, 3 years ago, and you were kind of an NAD guru in orthomolecular. And in my circles, I'm considered the niacin expert. It's a dirty job administering it if you don't know how. So the minority of doctors that still appreciate it, just send me the patients. I think I've titrated 5,000 patients inside of 21 years, something around that number.
That's a lot of patients.
Yeah, there are so many misunderstoods about niacin, and I take it personally, although I shouldn't, because as Todd pointed out, the coronary drug project, 27% reduction in MI, 5.5-year trial, 24% in stroke. If you're diabetic, it was 54% combined endpoints. And the blood pressure was chronically reduced by about 6 to 8 points systolic at the end of the trial. They didn't see any increase in diabetes or insulin resistance. It's transient at best. And it's usually an exacerbation you see when you don't know how to administer it. You should never give it fasting, particularly if the patient has any risk factors, because the vasodilatation will cause compensatory increase in heart rate. Catecholamines go up, and you've just dropped all the sources of fuel for the body, particularly the brain and the heart, down to 0 for an hour and a half. If you use niaspan, it's worse than that. Niaspan meant well, but the protocol really screwed everything up, because if you talk to Dr. Castelli, and he's no longer available, I don't get him on email anymore or over the phone, but he taught me the right way to use it. And it turns out much, much later, Dr. Tobias Kroon in Europe, I forget which Scandinavian country, or if it was Germany, but he showed that when you administer it with food, there's less problems. And it's actually far more desirable, because what happens after food. Triglycerides go up, insulin goes up, glucose goes up, and free fatty acids. Instead of a sawtooth pattern, taking it fasting, you get more of a sine wave pattern. And the total amount you take per day as one bolus is not likely to be as beneficial as smaller divided doses. So I only recommend patients take it with meals. I rarely use anything but immediate release. You don't want to chronically suppress the flush because there's a lot of authors on that, but there's a cofactor to PPR gamma and the prostaglandin metabolite as it breaks down. It's a horribly long name. We just call it prostaglandin J2. It's incredibly beneficial. PPR gamma is the primary, but there's also alpha PPAR and a delta, and they all move in the right direction because the most potent ligand in the body for PPR gamma is the metabolite breaking down from prostaglandin. But therein lies the problem, hot flash. Well, I'll compromise by suppressing it for a couple of weeks till the patient builds up a shield against the hot flash, because that's mainly a concern about compliance. I don't want them to quit. And I get about 95% compliance. I've had a few difficult patients, but a nurse in Florida couldn't tolerate 50 milligrams. I'd never ran into that before. So I gave her a 25 milligram strawberry flavored melt away. You hold on to your tongue. And she did fine. She didn't get up to a gram a day. My lowest target is 500 3 times a day with food, but she at least got to 150. But typical with women, they get a better therapeutic response. She's taking it long term. That's all I care. 150 milligrams TID. It's not a therapeutic level, but it'll help her kidneys and a whole number of other things. My wife is on 4.5 grams, and I am too. I don't have LP little a, but she does. If you want to get it down more than 40%, forget anything else, and don't put them on a stat. You'll increase their risk. I'm adamant about that. Dr. Sartorius Simikas showed that, and Dr. Zhu and several other papers published show that the statin does indeed increase it. And it's way more than most people parrot the quote. I hate these parroted quotes where they say niacin only lowers to 20%. Well, the PCSK9 inhibitors only lower at 17%. I've never seen less than 40. It takes a while to get there. It's a long siege, but I've noticed if I hold off on maximum titration, just get them part of the way there and then compliant, when they see the second set of lab work, their head explodes, because I didn't even know till the last 10 years or so, there was a lot more going on beyond the lipoproteins and the reduction in inflammation and oxidation. And it turns out, thank you, Todd, there's 400 genes that require niacin in the body. Top that. That silly little molecule is a miracle worker. It repairs myelin sheaths and accelerates the removal of debris. It is good for peripheral neuropathy. I've used it with Parkinson's patients, one of my closest friends. Almost anything that involves the nervous system, it's beneficial for. And they used to think, oh, it's hepatotoxic, only if you're unaware enough to use sustained release. Never happens with immediate release. Even if there's some renal or hepatic impairment, you're doing it good, because Dr. Modi Kashyap, who's now a good friend of mine, he helped launch Niaspan. He's got an indication to correct fatty liver all the way to the end, cirrhosis. That's pretty unique. But who's going to supply millions of dollars to get Niaspan back in the market when mainly cardiologists have been trying to kick it to the curb for years? I say, if you know it has benefit, great. If you don't know, read. And if you don't want to use it, don't condemn it. Give it to a patient, to somebody who actually knows how to do it. If you don't titrate niacin on somebody 5 times a week, you'll never learn how to do it. I do it a few times every day. Not today, it's a holiday. And a few patients that wanted to do an encounter today, and I needed a day off. But I love niacin. I probably have 40,000 reprints in my Dropbox. And I had to organize them a while ago because they're all meticulously labeled, but I sort them by the organ system or the benefit I'm looking for. And thanks to Todd, we published, you can reverse kidney disease with it. It's anti-proteinuric. I personally think it's the most efficient way to lower phosphorus. And God knows what else it does for the kidneys, but there's no question. A small dose will actually move the GFR about a whole stage backwards. And I had, thanks to Todd, the paper showed that if you use calcium carbonate, which is common, you don't even need to beat that horse because nephrologists start off with that. And then the concern is getting past 2 grams of elemental calcium to bind the phosphorus. So then they move to these horribly expensive drugs. Niacin inhibits, downregulates sodium phosphorus transporters. And when you get past 1 gram, you can get them to physiologic levels, not just KDOQI, KDIGO goes with 5.5, but 3.5. And that has a tremendous benefit, halting or inhibiting calcification, stress to the kidneys, the parathyroids, and so forth and so forth. So when I look at lab work, there's opportunities on every page of the lab work for niacin. The trick is getting them to take it and not quit. Go ahead, Todd. Sorry.
Oh, no, thank you. I just had one question there about calcium carbonate. I mean, can we avoid putting the calcium in there? I know that the idea is that the calcium is binding to the phosphate and
Right.
and all
Right.
and that you don't have, they say you don't have to worry about kidney stones and calcification, but can you just do niacin and sodium bicarbonate and stay away from that calcium carbonate?
Certainly, but there's still a benefit there because if I bind some of the phosphorus in the lumen, it's no longer available for absorption. Unfortunately, there's the feedback, which is undesirable, where they upregulate the receptors. Well, niacin comes at them like a giant hammer. It doesn't matter whether you have 1,000 per cubic millimeter or 100. It hammers them all down. But you could use it as monotherapy. But if this person can't take very much niacin, the calcium carbonate is still a good candidate because I use small amounts because most of it will bind the phosphorus and it's unavailable to be absorbed, and it's more or less the irreversible bond will go out in the feces, and that's where it belongs. But there's a number of things in play there, and I spend 90% of the encounter teaching the patient why niacin is important, how to take it, how to not fail, and if they have to, how to manage the hot flash. And my wife was the most difficult niacin patient. Thank you, God. But I got her on.
Excellent discussions. Thank you, both Todd and Stephen. And we have some non-medical professional people here. But anyway, as a physician, I've been learning about niacin, using niacin, and let me give a sort of my clinical perspective. I'm more interested in the clinical application, what it does to my health and the health of my many patients. I do understand science. I do have a PhD in biochemistry as well. But many years ago, I came to orthomolecular medicine, and I really felt great. And when niacin, actually, to me, is one of the probably most important vitamins. The key of the science here is because it is the key molecule that drives up our energy metabolism. And we all know this world, money drives the world around, and life revolves around energy. My PhD was in molecular biology. We studied so much about genetic mutations, but I didn't realize until into my more advanced age that actually energy is what drives life. Genes are only executioners, so to speak. Genes are there to execute the functions. But so niacin is critical for our energy metabolism, our muscles, and everything that we need. more than anything else. We know biochemically, niacin is involving more than half of the biochemical reactions, as Stephen and Todd alluded to earlier. So I've been using niacin in practically, it is part of my protocol applied to practically every patient. Specifically, we know niacin clinically has been shown to be effective in not only lipid regulation, lowering, boosting HDL, they think, but also in autoimmune disease, in cancer treatment, and in like Todd and Stephen mentioning reversal of renal failure. I've seen a few cases as well. And so interesting enough, I'm a kind of person, my approach is that if something is safe, first of all, whatever I do, whether it's, whatever the natural agent, now I mostly use vitamins, natural agents, very few prescription drugs. And so whatever I do, first of all, is make sure it is safe. The safety of niacin has been documented extensively. Let's all remember, niacin is one of the very, very few, as far as I remember, I think it's the only vitamin that's FDA approved. And the approval dosage is 500 milligram, or recommended FDA dosage is 500 to 2,000 milligram. So this is, unlike other vitamins, this is FDA approved. So I've been using niacin, and interesting enough, my starting dose, is 500 milligram. I'm kind of, if it's safe, if it works, I usually, we start with 500. Let me tell you, of course, I warn them in advance of the flushing and everything, and take with meal. I haven't had any, we've used at least hundreds of patients, maybe if not more, probably more. But with the warning, everything, usually we haven't had anybody who, except the one person who didn't read the instruction carefully. I think that was a man who took like 2 or 3 500 milligram capsules. He had a bad flushing effects, but now he's on it again. So to me, it's very safe if well educated, and we educated patients or clients in advance, and that's not a problem. And we've seen a lot of diseases. Actually, this is very exciting, is that we've been using niacin as part of the integrated protocol. We have reversed, 7 cases of atherosclerotic cardiovascular diseases, including carotid plaques and the coronary stenosis. And actually, I'm writing up for Orthomolecular medicine publishing. And we've also we've reversed quite a few autoimmune disease cases as well. So in summary, to me, we need to take whatever we do, whether it's a vitamin or a lifestyle diet or a prescription drug, we need to take into account all the other factors, not judging by one mechanism or one aspect of the thing. So my conclusion is, all things, considered, the niacin benefits outweigh the potential, whatever the side effects they say they may have. And all my clients are pretty happy with it. And so let's hear some any questions on niacin from our audience. And it's 9:24, and so we wrap up this subject and then move on to the next in a few minutes. And if you're not talking, please mute your mic. And when you talk, you can unmute your mic and ask your questions, and so we can answer them. Any questions on this subject?
Good morning. Is it okay if I chime in?
Yes, please.
Awesome. My name is Terrell. I'm calling from Salt Lake City, Utah. I have a question regarding, I've read a little bit that high-dose niacin can deplete methyl donors. And I wondered if you've seen, maybe in labs or something, if like homocysteine elevates over time with high-dose niacin, or if like just taking your B complex is enough to reduce that risk.
I'll jump in, I guess. I see it all the time, not frequent, but it's mostly people with methylation deficiencies, particularly like myself, 677TT. But irregardless, if it goes up, and I remember Dr. Castelli saying he'll fix the homocysteine, not lower the niacin. And you got to understand, if you're treating something, which pathology you're treating. You know, kidney disease responds to 500 milligrams or less. Lipids, it's got to be at least 1.5 grams, with or without another adjunct. But if you're treating LP(a), 3 grams or more. And the methylation problem can be overcome with donors like betaine, trimethylglycine. There's an inexpensive methylfolate methylcobalamin called Triquetra. You can get it on Amazon. I know some people might be concerned about purity, but you know what? My patients don't, they're not rich. So if I can correct the homocysteine with something that costs less than 50 cents a day, that's good. And if that doesn't work, I have a sequence I go through. And the last 2 things I might use would be choline or krill oil. And because krill oil has phosphatidylcholine, and astaxanthin, and sometimes I'll see a flavonoid like quercetin bring it down. You have to kind of start with the conventional approach, and if it doesn't work your way downstream. Because I've had a couple doctors that had horribly high homocysteine, and it took me 2 or 3 years to figure out what key would unlock that and get it down. But I got there. The choline is actually pretty good. Vitamin B2 works real well. University of Ulster in Ireland, they got 25 years of data following up on the same cohort. If you're 677TT, poor methylator, it brings blood pressure down anywhere from 8 to 12 points systolic. I'm one of those people. I actually stopped my ARB and my Triquetra, so it was treatment naive, and then they added the riboflavin, and it brought it down quite a bit. I think it was 6 to 7 points systolic. Then they added the Triquetra, and finally the ARB I was on, irbesartan, and that completely normalized my blood pressure. And because I was a poor methylator, there was a lot of issues there. But the homocysteine is what they were focused on in the Ulster trial. And if anybody wants that, I'll send you the Dropbox folder. There's a lot of publications. There's 3 really good colored slide decks that kind of walk you through it. It's fascinating. I don't care if you're a poor methylator or not. It does enhance the reduction of blood pressure. And in China, that's the big deal with the CSPPT trial. They were given folic acid. They weren't even given methylfolate. And on top of an ACE inhibitor, enalapril. And of course, one group got fake, placebo. And at the end of the trial, huge trial, 20,000 subjects, they showed that the reduction in stroke was 21% greater with the folic acid, not even methylated. And then the ones like me who couldn't methylate well, it was 76% further reduction relative to the normal group versus placebo with, I think it was 0.8, 800 micrograms of folic acid. And proof of principle was clearly there. So, Ireland was focused on the riboflavin and the poor methylators and blood pressure, and the CSPPT proves that when you add them on a blood pressure drug. And in China, they don't have a lot of food fortification, so low folate is rampant, and H-type hypertension, homocysteine type hypertension is also rampant. So their answer to that was, some form of folate, but they looked at the renal sub-study and it was slowing it down. Way less were ending up on dialysis, or at least stage 5, versus the group that didn't get the folic acid. And it's good for uric acid reduction. I learned a lot from that group of studies. I have a folder just for CSPPT, but that's fascinating stuff.
Actually, I want to mention something here. I've learned most physics. One thing I observed that most of us actually, most of us have been trained to focus on mechanisms. Here we're talking about homocysteine. I think this is a great example. So when we talk about homocysteine, we focus on the mechanisms, the science behind it. It's great, it's excellent. We need to learn all that. However, I always tell myself, take a step back. The point I'm making is actually, if you look at the diet and the toxins, so you will see the diet we are having today, we're eating today, having a lot to do with the homocysteine levels. The poor diet, the high carb diet, the high ultra processed food diet, a lot of environmental toxins, actually those will drive up your homocysteine levels. In addition to the nutrition, particularly B vitamin deficiencies. The point I'm making here is that I always tell myself, I have these, lectures talking, I always teach, go to your root causes. Like many others, we're talking about here, we're talking about, for example, oxidative stress, mitochondrial genetic mutations. These are all mechanisms, including homocysteine. And there are one step further before that, that's the root causes. So I would advise that we go to healthy diet, cut out all these unhealthy, ultra processed foods and all these things, and supplement your basic essential nutrition, regardless your health status. And you know what? Actually, I found, including homocysteine, among my clients, I haven't found very high level of homocysteine levels. So I always advise go to the root causes before we focus on these mechanistic issues. All right. So any other questions on niacin? Because we're already 30 minutes into it, and we have at least one other subject we want to touch on. And any quick questions on niacin? Let's keep our conversation tight.
Cool.
Hi, I'm Cindy. I have a quick question about the side effects. I know everybody talk about the flushing, which I can deal with, but the problem I'm having is I'm getting hives. When I take niacin, I get hives all over my body, and they last about a day or two. So I kind of stopped taking the hives. Is that normal?
First of all, let me ask you this, because we get these questions all the time. Are you using here's the question is that, are you reacting to niacin per se or the potential contaminants in it? So make sure it's pure. Let me, for example, I've got quite a few questions to me about vitamin C reactions. Now, the vitamin C I use at least 99.5% pure or even higher. And so whenever I ask these clients, they oftentimes use vitamin C in a mixture. So the first question always is, are you reacting to whatever think you are, or maybe something else? And in my experience of at least hundreds of people, other than the niacin flushing, we haven't seen hives like what you described. We use very high purity niacin products, instant release always. Any other part, Stephen? Any thoughts on the hives?
I've had a few like that.
I'm sorry. Let me make one thing. Human beings, we cannot be allergic to pure niacin, pure vitamin C, pure vitamin D. Why? Because these are vitamins. What are vitamins? If we're truly allergic to this vitamin, we cannot be alive today. That's my point. See what I mean? We cannot be allergic. Yeah.
So I guess the question comes down to is, even though that niacin supplement says it is only niacin in it,
we never know. We never know.
Okay, we never know that.
I doubt. Like I just mentioned, we cannot be allergic to vitamins. Other things may be. Vitamins, by definition, our lives depend on vitamins.
Okay.
We cannot be allergic.
Okay. So it's nowhere the source to obtain.
Find change a different source.
Perhaps it could be controlled with just lower doses. Yeah, I don't know, but you would know.
Yeah. Stephen, yeah.
when I first was asked to set up lipid clinics, we didn't know anything. I was dumb as a rock, but I knew niacin worked and it had a tremendous legacy of outcomes. And the HATS trial, 90% relative risk reduction, number needed to treat less than 4. And even without a statin, they were seeing 60, 70, 80% relative risk reduction. They went out 25 years with the cholesterol studies. And I knew it worked, but how do you use it if you don't know how? Well, we just dove in, and very quickly the girls on the office staff started really giving me dirty looks. Then I heard them arguing with a patient. They had to pull the receiver away from their head. It was yelling and swearing. And Dr. Dave said, "Man, you better fix it." He goes, "I can't keep the girls away from you too long." And I was imagining walking out of the practice as a eunuch, because they were mad. So I asked Costelli and a couple other people. Turns out flavonoids work, and I'll get to that, but there's a serotonin and a histamine pathway, and usually people who take the aspirin, we were using Alka-Seltzer like Costelli. There's still about 1 out of 3 that have a hot flash, and some people perceive it's an allergic reaction. Well, it's not. You've got to get them on board for at least 2 to 4 weeks before the tolerability kicks in. And while you're titrating it, it isn't the dose that causes the side or the lack of side effect. It's the persistence of compliance. You skip a whole day, you're going to run into a problem. Even 12 hours might provoke it. So if they're doing extended fasting, what we did is we just took what I learned from Costelli and a couple other lipidologists, and I made a protocol, and I learned how to think more like a patient. I made it look funny and colored pictures, 3rd grade reading level in Spanish and English. It was called the Alka sauce protocol. An Alka-Seltzer and 3 tablespoons applesauce. And we didn't understand the benefit of the hot flash, so we just panoramically suppressed the flush. And it worked. We got 95% of them on niacin, took them out beyond a year. And like Dr. Said earlier, Dr. Richard, we were stunned. I was expecting it to be like the trials, 3 years, 5 years. No, all the angina disappeared within 3 months. Our admissions dropped pretty much to 0. We didn't have an acute coronary syndrome for 5 years. Roughly 5,000 patients, and Highmark Blue Cross Blue Shield documented the data. Nobody wanted to act on it, which is idiotic. They could have saved a fortune and better competed with UPMC, but suits don't know this stuff, and they make all the decisions. So they didn't care that you could reduce outcomes that dramatically. But I believed it. Then later I realized the flush should not be suppressed long term. So if I have to, I give them the Alka-Sauce protocol, Alka-Seltzer and applesauce, and that'll get them through the first month. And then I check if they remove it for a couple of days, are you still doing okay? Did you take it every day? If you took it every day, you might be able to remove the anti-flushing regimen. And I like to paint pictures because I'm usually doing it over the phone, no video, and say, well, it's like ham and eggs for breakfast. The chicken made a contribution, but the pig made a commitment. You got to make a commitment to niacin, then you get the miracle. Because if you stick with it, it gets easier and easier. And when you get the first set of labs that follow up, it's dramatic. Dr. Richard, I'm sure, has seen that a million times. It's just fabulous what happens in the lab work. It's a nickel a gram. I never used anything but a media release. Rugby's probably the oldest manufacturer. But however you need to do it, get them on the niacin. Then everything else is relatively simple. I mean, I use a lot of berberine and milk thistle and flavonoids, but niacin is king. It just is.
I agree, Stephen, absolutely. Let me wrap up on this subject and move on to the next one. We have Dr. Downing waiting, and I think that's going to be an excellent project. But finally, let me just summarize. I'm 64, turning 65 in a few months, and one of the things that I'm really concerned about energy is that I play badminton. against people half my age. Many of them are in their 20s, 30s. And you know, competitive badminton is competitive, you know, it's intense. So I've been interested in this energy, mitochondrial energy production for 15 years. I've been playing badminton for 15 years. I think niacin really has helped me because it has been helping me to grow muscles, to make sure I have energy that I can play. Endurance. You know, a physical exercise endurance, I think, is a very important hallmark of your health. Our body, every cell in our body needs energy, and most of our cells have to make energy in its own mitochondria. You cannot import ATP to do it. You have to make it on your own. So healthy lifestyle, exercise, diet, niacin, and other vitamins are the key. All right. Let's move on to the next subject. Dr. Damien. Damien, are you there?
I'm here.
Yeah. So the next question, I got a couple of emails. They wanted to hear about this light. Let there be light. So yeah, go on. You have the mic.
Okay. So I wrote a book about this 40 years ago called Daylight Robbery, nearly 40 years. And that came out of meeting a guy called John Ott, who was not a doctor at all, but he was a guy who used to make time-lapse photography movies for Walt Disney. You can still get some of them on YouTube or whatever. And he had a lot of challenges and it became clear that the entirety of the spectrum of light was necessary for fruits and plants and so on to mature in the right way. And then he had a shed down the bottom of the garden, and he had bad arthritis that he used an old bicycle to wheel down to the end of the garden. And then he broke his glasses, and this was in Chicago, and he couldn't get a replacement pair in time. By the time he did, his arthritis had improved so much that he raced up the stairs to tell his wife that he'd never been able to do for some years. So he figured out a lot about this with you know, a completely fresh attitude, not fettered by the, you know, the scientific perception or whatever. And that was the start of a snowball of discovery, because in the 80s was just about when lasers became useful. And so there was, to begin with, in Russia or behind the Iron Curtain, and then in Germany, and then, you know, everywhere now, there's a huge amount of research happening on.
I think it stands for like grade A. Do you know what the A in Chick-fil-A stands for?
What?
I think it is, because 100% chicken. Okay.
I'm sorry.
Grade A chicken.
Can we?
That's not really relevant to our discussion. I just muted it. Go on, please. Yeah.
Right. Okay. So now there's 600 or 700 studies a year coming out, a lot of them coming out of Brazil, very interestingly, showing that you can do an amazing amount with light. And Rich is entirely right. One of the key things is the impact on mitochondrial function. And the reason this is that when you think about 50% of the energy that we get from the sun during the day is in the infrared part of the spectrum. So it's not visible light, but you can feel it. You know, you go out in the sun and you feel warm. And we kind of know that that has an impact on, pretty direct impact on the mitochondrial production of ATP, the main energy currency in the body. And actually now we're starting to think that it's, does people know about the Pollack's work in the fourth state of water? So this is what sometimes, yeah, great. Sometimes what's called marginal water. You put water into contact with a charged surface, and its molecular structure and its properties alter. It's called, they described it as exclusion zone water because it takes up a thing. This explains an awful lot of things that happen. You can do some remarkable stuff. You can get Pollock on YouTube easily enough doing a TED talk. But this is, so with light energy impacting water in our cells and so forth, you can actually get beneficial effects that we had no idea of. You know, we were laboring away doing, you know, developing fancy medicines and so forth, and for God's sake, we should have been getting out in the sunshine. And there are other people who have demonstrated that, you know, over the years, as we've moved indoors, we're getting less and less of the infrared energy because we're not outside to get it from sunshine. Incandescent bulbs used to have some in, but now we're all going onto LEDs, which don't have any. So we're light deficient, but it's particularly, well, it's predominantly infrared, but it isn't only infrared. And the other thing is that because electric light enables us to ignore the daily cycle of the sun and light and the dark, as it carry on into the night, we're also dark deficient because we're designed to have that part of the cycle as well as the sunlight part of the cycle. So we're doubly deficient. And that's why it's, I mean, it's so easy to just get some benefit here. You know, you can all do it for yourself, just get out into the sun. Tell the dermatologist to shut up about, you know, having a put sun factor on if ever you get a shadow from yourself. It's utterly ridiculous. It's certainly encouraging other cancers than skin. And frankly, if you wanted to have a cancer, what would you pick? You pick a skin. I've had 2 cancers. I got rid of one basal cell with the Curaderm stuff, the aubergine treatment, and I had another one cut out that was a bit large. But you can spot the darn things. So we'll do an awful lot of harm to ourselves. It continues to get worse in that time. In the time that I've been a doctor, which is 50 years now, cancer rates have quadrupled. That's obviously not because of a change in our genetics. Sure, a lot of it is the environmental pollution, the microplastics, so on and so on and so forth. But I suspect that the other side of that is that it's due to light deficiency and the loss of a normal diurnal cycle. So, have I got on enough?
Yeah, actually, I just want to add, recent study shows that the early onset of cancer among the population younger than 50 increased by 80% in the last 30 years. That's amazing. You know, yes, not only the light, but also our diet, the ever increasing synthetic chemicals. Amazing. I think there are, correct me if I'm wrong, there are over 80,000 synthetic chemicals out there, not well studied of their safety.
No, we're well over 1 million now, Richard.
Oh, over 1 million. Oh my God.
Yeah.
Oh, we are underestimated. Yeah. And light, actually, Damien, great lecture, great paper. And I came into, it's interesting. In a way, all were told plants can do photosynthesis, humans don't. Well, we don't do photosynthesis, but I think this near infrared light, or the so-called PBMT, photobiomodulation therapy, basically light therapy, is form of photosynthesis in our humans. You know, we can directly make energy. Unfortunately, not enough. We cannot skip meals, you know, but it's fascinating. Coupled with methylene blue, that will be subject of another time. It's fascinating. Let me share with you a little bit of my experience. And I kind of, Dr. Thomas Levy, my mentor into also molecular medicine, and shared this little book with me many years ago, several years ago, and which led me to methylene blue. And I knew about the light therapy way back. But anyway, So the more I look into research, these so-called published, peer-reviewed journals, that, oh, amazing. I have practically found these clinical studies of benefits of near-infrared light or PBMT effective in practically every aspect. Starting from, we all know hair growth, which we're all concerned about, skin, the beauty, the beautiful anti-aging effect, and also on heart health. At least one study showed near-infrared therapy improves left ventricular ejection fraction or the heart function. Also increasing the testosterone levels. Also, it decreases our blood sugar level, believe it or not. You shine, you stay under the red light. I think the study was like a decrease of blood sugar by 17%. It increases our energy production. What else? I mean, everywhere you go, you will find, I think I found yes, improves our dysbiosis, basically the disturbance of bacterial flora in our gut, practically everywhere. That highlights what Dr. Dunning just said, we are sunlight or we're light deficient. So interesting enough, and now it's, I just was curious on finding everything that is available and affordable to us and that is safe. Light is one of them. As I'm talking right now, right there, there's a light box right there. I'm having it on all the time. I don't know, I have a lot of light in my, I give to everybody, my parents, my family members, and I tell them, just go stay under it. As of now, I mean, well, there was one study at least that near-infrared actually improves vision too. That was 2021. I think that's probably the only one that I know of. Of course, safety, and I'm very curious on that on that subject because my vision is not as good, Anyway, so light therapy is so critical, that it's so inexpensive, by the way. You can have a light box, or you go to the outside, go to the forest, go to under sunshine. These are very expensive, Anyway, so any other comments?
Did you say there were a couple of questions?
Any questions? So what I'm curious about this, I think we had a discussion with Todd. Actually, Todd is the expert, is one of the experts on this subject. He's spent I forgot how many years, quite a few years on the subject. Here is the thing: is that the dosage of light, the penetration, how much light, basically the wattage, how powerful our light source should be in order for the light to penetrate into our body. That is a question, a very important question. And maybe Todd, you may want to share some of that.
I was just trying to talk a minute ago and I had mine on mute, but I wanted to back up what you're saying, like about the blood sugar, for example. I'm writing right now about a patented tri-wave photobiomodulation therapy that shockingly really does reduce the blood sugar. And there's studies that show remarkable responses for the thyroid of people that had, not entirely
Yes.
resected. There's just so much, I mean, there's literally thousands of papers, like Damien pointed out at this point. As far as the depth of penetration, a lot of these cheap things, they work wonders for shallow tissues, like rural leg ulcers and diabetics, non-healing foot wounds. I feel that everybody should be using that. It costs nothing and it's incredible. There's always a case study coming out with just incredible graphics of these foot wounds. Is a perfect example. Oral mucositis is the one indication. It happens in a cancer after a lot of chemotherapy, and it's so awful that some people, they request a feeding tube. But the story was about 10 years ago, a nurse had a patient that wasn't getting this horrible side effect of chemotherapy and bone marrow transplants, and she was a dentist, and no, she asked what was going on, and the patient said, "Oh, my daughter's a dentist. She's doing a red light." And now the clinical trials are done in Brazil and all over. They're completed, and now it's reached the level of guideline directed treatment. You get the red light, and the red light is so simple that you could buy one on Amazon for $40 and it would work just as well. The parameters for this. So they do the mouth and the oral cavity and all that. And it prevents the oral mucositis. And now it's even covered by insurance. It's the first photobiomodulation therapy that's so it's everything's on the up and up. I have personally been focused on the importance of high powers. So I can show you my laser right now. I have to turn off my blur, and then you should be able to see. This is my laser, and this is these are expensive, but they are doing just too many things. I mean, there's people, it's been shown to work with depression. I did a case study for somebody that lost their memory, and they do like 30 watts, like hot, high powered. And I'm starting to do this myself every morning. I just do it because there's just so many things, cognitive function, everything else. So it's really in the discovery phase with the high powered stuff that reaches deep. But then you have to be careful because there's people selling a lot of LED, like low powered devices, and making false claims. And there's some good things with those, good outcomes, but a lot of them aren't sustained, and they're not true. That they've done all these tests with sheep brains and pig brains, and it's not really penetrating beyond the skin. A lot of these low powered things, but it's absolutely remarkable what's being done in that whole field.
You're showing your laser. Can I show you mine?
I'm sorry?
Can you show us your laser? Can I show you mine?
Go ahead. Yeah.
There's this thing here. It's called an endolight. You put it on the wrist.
Oh.
And it's got 2 rows of lasers there that shine into the blood vessels on the wrist there and carry it around the body. So that's a workaround for the very real problem that you're describing there. You know, if you have to make a power one. I mean, we have different areas of expertise in this, really, you and I, don't we? And there isn't really a conflict, but this is another way of doing it. And we use a lot of.
I totally agree. Yeah, I and that diabetes stuff I was talking about, it's low powered. It's like you said, the blood comes by and yeah.
Yeah, you said tri-waves. Well, which 3 wavelengths is that then?
I'll have to look it up. You can keep talking. I'll have to look it up.
Is it important?
That's a good question. Actually, the 2 waves that I've been reading a lot on is one is the near infrared. I think that's a 50 nanometer or in that range, and the other is the in the red. I guess it's the 660 nanometer. Seem like those 2 wavelengths have received seem like more attention than the other wave. Of course, varies. Or the whole spectrum of sunlight is critical to our health, but those 2 seem to be a little bit more dominant.
Yeah.
Well, sorry. Should I do that?
Go ahead,
it is the it's the 50% of the sunlight energy is in that, so it makes sense that we're designed to take advantage of that straight away, and also they have the best penetration other than the far infrared, and so forth, much better than the visible. But you do get other specific effects at other wavelengths, including the visible.
Yeah, I find the full spectrum fascinating. I really look forward to reading your book. When it becomes a really high power, that's where you want certain wavelengths that don't absorb water so much.
Yes.
And so, for example, the high power really exceeds exceptionally as compared to low power in your joints, like with knee arthropathies, because the joints are largely avascular. So, it's been a challenge with low power that the results are not as good. but yeah.
I
But
see a few questions. I'm sorry, a few questions on this. Somebody asked about the mental health. Yes, both niacin and the light therapy we're talking about have very excellent effects on mental health. We didn't mention about the niacin on, for example, Todd, correct me if I'm wrong. I know Dr. Hoffer used the niacin in high doses up to, as far as I know, 12 grams a day for depression, for schizophrenia. Dr. Hoffer, the founder of International Society for Orthomolecular Medicine, was a psychiatrist. He has expertise. One of his areas is in niacin, and he used very high doses of niacin to treat depression and schizophrenia. We've been using that too. Amazingly, this is interesting. You know, I've been an internist, except when I was in medical school, internship and that sort of thing, I met with schizophrenic patients. Now I have been able to help 3 schizophrenic patients, adult schizophrenic patients, to halve their medications and improve their overall life quality and also family relationship, amazingly, using what? This sort of orthomolecular medicine approach, diet, nutrition. So niacin is a major part of it. Somebody mentioned here, yes, the person commented they love the flushing. Me too. I have quite a few patients telling me they love this little bit warm sort of effect. Yes, I do that too, because I eat 2 meals a day. We're not going to talk about fasting today because we're running out of time. But I only eat a lunch and a dinner. So usually like between 12 and 2 p.m. and the dinner is like 6 to 7. And I take niacin with it. I feel good. A lot of my patients use that. And the light therapy also has very excellent effects on improving mental health, improving the sleep, depression, and other issues. Yes.
I'd like to reinforce what Dr. Cheng just said about the hot flush. I like it. I wish all my patients did, but that's not the case. But I try to leave little sound bites in their memory that, when I have a patient, whether they give me a hard time or not about the hot flash, within a week or so, they say, is it normal to feel sharper? I don't have brain fog. Is it normal to have more energy? Is it normal for my knee pain? My knee pain went away. It's a list. And I don't discourage it. I don't lie to them, but I tell them, look, it's quite likely the niacin helped, because the bottom line is your circulation never looks better, particularly the microcirculation, than that hour after you took niacin. And that's why I like them to do it more than once a day, because you're getting a burst of NAD, you're getting a flood of circulation. Yeah, you have a hot flash, but you're purging toxins and bringing in nutrition and oxygen way more rapidly. Podiatrists used to use it. I think they still do. The older ones, like the 80-year-old guys. Oh yeah, it reduces amputation rate because they're usually dealing with a diabetic foot ulcer. And if you can close it and heal it, it reduces the odds that they're going to have an amputation. And that's fallen out of favor thanks to these idiots that are bashing niacin. And every one of these negative studies can be meticulously dismantled, but it requires knowledge of niacin, and most of the people that publish negative data know nothing about it, probably never used it, quite honestly. Cleveland Clinic really made me mad. I sent the link to a paper that came out before Cleveland Clinic. Turns out the very thing they were trying to prove was negative was actually positive. And those investigators weren't so biased. They went in thinking it's a renal toxin. Well, it turns out it reduced fibrosis in the kidneys and inflammation. Excuse me? Where did Cleveland Clinic get their data? I'm not going to say, but it was clearly uninformed, and none of them knew anything about niacin.
Let's come back to the light therapy. The light therapy is really excellent. One day, hopefully, and I had a conversation with Todd. Actually, I like to, when it's possible, I like to have a light box. The light therapy, I like to stay in it. Actually, I've made a recommendation to a couple of healthcare institutes in Shanghai, and they are trying to get me to consult for them. But anyway, yes, that is definitely on my to-do list. I like to have a light box or small house that I can go in there, spend 1 hour or so every day, So yes, light is really, so basically the more natural ways we learn about it, the more we need. You know, I keep telling people, I said, don't forget, you know, this is how I say in Chinese. But anyway, what I'm saying is that after living in high-rise buildings with suits and ties, we forget we are actually animals biologically. What animals you see eat 3 square meals a day and wake up with a breakfast? All we're doing, most of the things we're doing today is against the nature. And we know our human body doesn't like unnatural things. So that is the source, the one of the main root cause to our diseases. That's why we see early onset cancer increasing by 80% in just 30 years. Unbelievable. Yeah. And any other questions on this subject? Talking about the knee pain. 15 years ago, when I started playing badminton, actually I had this knee issue and then my shoulder issue as well. You know, I was in my 40. I mean, I was in my 50, 49, I think. Anyway, so I started changing my diet, increasing my nutritional supplements. You know what? I can now I compete at least 2 hours every other day on the badminton court against young people. How can I have knee pain if I have any issues? So diet, nutritional supplements, light therapy, exercise, intermittent fasting, it's the integrated approach, not just the one. So that's the important message I like to deliver to to my clients. You know, don't focus on one issue. To look at the big picture.
We've got a hand up here.
Yeah. A hand up.
Somebody's raised.
Yes.
Cheryl B.
Thank you. My question, I have like 2 questions. The one is, do we have to worry about our vision having the light on us? I mean, I'm kind of a little concerned about that with the retina. So is the light right in your face, or you have it on the sides, or how do you do that? And the second question is, you're saying that the more of the deeper, in order to get into someone who has arthritis, are there devices on the market that one can purchase as a layperson that would help one's joints with that deeper, or do you have to go to a clinic to get that? Thank you. And thank you for doing this.
Okay. Can I answer the first one and then
Go
pass you over to Todd for the second half of this? Yeah, I was worried about doing the light on the eyes and could it be harmful and so forth, but not anymore, because there is now actually some evidence that, for instance, getting kids to just look at a red light unit for a few minutes twice a day actually improves their vision, and they need less correction, less glasses, or they leave them later, that kind of thing. And there's even there's clear evidence that light therapy of this sort can benefit the dry form of macular degeneration, which is the less severe form, but actually looks like it can probably benefit the wet form as well. Only it's it's later on in the process that you get the wet form, so it's tougher to get an improvement. And you have to bear in mind that a lot, particularly in the infrared and indeed the red, a lot of the stuff that, a lot of the light energy that's getting into the eye on a normal day-to-day basis is not through the open eye. I mean, that's what happens when you close your eyes, and what do you see? You see red. And because there's red light coming through, and so even more there'd be infrared. So that stuff's bathing the eye from all sorts of directions all the time, not just through the retina. And you can get some clear benefits from using it there. But you know what Todd and we've all been saying, really, the numbers are important. and you have to be careful with all of this stuff. Generally speaking, with the low-level laser type therapy, the way it seems to work is that the benefit, the more you give, the more the benefit, until you reach the point where you get thermal effects, where you're overheating the cells, the tissues, and then boom, you're down from benefit to adverse effects. So you have to avoid that point. But I expect you've got some more to say about that, Todd.
Yeah, there's a company called Lumathera that it's still not FDA approved, but they have this big box like you when you're at the optometrist, and it does the right wavelength, whatever. It's getting really great results, but I think what Damien's saying is really exciting because it's my guess that if somebody would do the basic research and had just a light meter, you could probably go out in the sun and figure out, okay, now's the time to look at the sun, or maybe with these glasses. I mean, but that's a scary experiment, right? You don't want to experiment on your eyes. But it would be so interesting to read Damien's books about all that, because that's clearly something we could all benefit from. Lumathera is working on age-related macular degeneration, which is, I think, like the second or third, maybe the most common cause of blindness. It just gets us all. The light therapy for the eye totally works. You just can't mess around with it because your eye concentrates whatever it is. You have to know what that power is and all that stuff. And some wavelengths are hotter than others. So you don't want to play with that. I wouldn't say. Rob Smith will tell you as well. But as far as the deep tissues and all the arthropathies, I'm currently in the process of, I've been working on this for 5 years, and it's huge meta-analysis, and we have 55 clinical trials for high-powered photobiomodulation therapy, these high-powered lasers. And there's more than anything, it's arthropathies that there's the most data, and the powers are typically like 10 watts. And to finally answer your question about how to get these, you can get them on a used market for a few $1,000s. And you can consult with me on that. And then I know the company, I work for the company that sells incredible devices. And then you can also go to practitioners and do programs with them. I mean, if you can pay for 10 sessions, whatever it is. Typically you want to do maybe 2 weeks of every day, but something regular, because when you're dealing with arthropathies, you might get the stem cells to grow a little bit, but then you're just smashing them when you stand up, because you're trying to grow something between a hammer and a nail there in your joints. So you need to do the light therapy with something high powered, typically 10 watts, 30 watts, 80, even 80 watts, and then give it, do it regularly and try to get the trend towards some growth. They've actually shown increased cartilage growth after light therapy in the shoulder and in the knee.
Yeah. The only thing I can add is I mentioned the study of back in 2021 of the near infrared. I believe the light wave was the combination of 850 nanometer and 660 nanometer. If you're not talking, please. Okay, I found the source. Anyway, so that study was it was directly looking into the red light. I may need to go back on the wavelengths, but it's one of those two, or maybe both. For 3 minutes, looking to the light source, they had like a binocular type of thing, looking to the light source for 3 minutes. I think it was like twice a week, only twice a week. And they found, I believe it was 17% of vision, 17% of the visual acuity in, I think it was 3 months. That was pretty impressive. And I was so curious, I really want to know more about it. But as you, Cheryl mentioned, safety is a concern. About red light therapy, I've been looking for, I have not found any significant side effects whatsoever of light therapy. And that's the beauty. And of course, most of the studies were in, sort of institution settings. You can only go to these places, how long, I mean, it's expensive, right? So usually the studies were like 30 minutes. This because that you have to go to a place to sit in for 30 minutes. But the eye is the only concern I still have, about the intensity, the dosage, these things. But I do know one study at least. Dr. Darling was absolutely right, because the light therapy improves myopia of young children and macular degeneration. And I like to see it also improve the old man like me, because when I play badminton, I found I miss shots, because normally no problem. But when you're in that very competitive, rapid thing, I need my better vision. And that's one of my things I'm waiting for. And I don't know the answer of, I haven't found the details. I mean, I haven't found any laser device on the market that I can use to improve my vision. What I've been doing is, like Dr. Dunning said, I close my eyes, look into the light source for like 3 minutes every morning. Okay. So any more questions on this? Or other subjects? We have, let's see, let's keep it within 90 minutes. I think we scheduled for 90 minutes. Yeah.
I'm going to have to go, actually.
Okay.
So if there aren't any more light questions.
Yeah.
That's good.
Yeah, and that's oh yes, Andrea, please go ahead. Unmute yourself. When you talk, unmute your mic. Andrea, I cannot hear you. Your mic is muted. Okay.
There we go. Sorry. It was a question before you go, whether you had any recommendations of UK brands of light.
I just sent you a recommendation.
Oh, did you? Okay.
Yeah. But of course, it comes straight from the factory in China.
Thank you.
Like everything does these days, doesn't it, Richard?
Still yes. Well, I don't know what's going on with this trade wars, Okay.
Okay. All right. Thank you very much, folks. It's been interesting. Hope you forgive me going.
Thank you, Damien, for joining us.
Thanks. Nice to see your faces.
Yeah. Yeah. First
Bye-bye.
time.
Thank you.
Bye, Damien. Any other questions, folks? We have a few minutes left. We're recording this, and we will upload onto YouTube and maybe some other platforms. And this is our first one, and hopefully we will have more interactive platforms helping us to all grow. Well, we're finished here.
I have a question.
Okay, go ahead, please. Who is this, please?
It's Gregor.
Oh, here you go. Yeah, I see you. Go ahead.
This is a question about niacin, and like, I'm not an expert on niacin, I'm just a lay person. But niacin used to be called nicotinic acid, and is nicotinic acid related to nicotine? Does it go to the same receptors in the brain, or is it something completely different?
That's a great question. Actually, Todd and we had a conversation, and Todd mentioned, I said, oh, this is confusing enough. Let's not read anymore. Todd, you want to answer that question?
It's
Sure.
the same thing. Go ahead, Todd. Sorry.
I'll just put my 2 cents and let Stephen take it away. My understanding is that the nomenclature, like nicotine, I think it's somehow related in a pathway, but they're completely different molecules. Yeah. They're very different. Niacin doesn't do all that.
Somebody had asked nicotine, as Todd said, 2 different things. However, nicotinic acid, it's a big phrase. They truncated it to niacin, meaning the nicotinic acid vitamin, IN. So they took favorably whatever words made a nice single word, niacin, but it's the same thing. And don't confuse it with NAD, because that's a metabolite that comes out of the liver after the first pass. And if you want a lot of NAD inexpensively, don't be a child, be an adult, titrate the niacin. There's a guy who did blood measurements of every form, NMN, NAD, and he took plain niacin and his NAD levels are very robust. So don't confuse no-flush niacin with the real McCoy, because real niacin, that's why people avoid it. They don't know how to avoid the flush or how to titrate it. But it's so cheap, 5 cents a gram. With inflation, I think it's 5.2 cents a gram now.
Yeah.
You know,
Actually,
yeah, God made it. Therefore, there's no real profit there because he's not looking for money.
I'm sorry. Yeah, actually, niacin the other is known as nicotinic acid, and the other form I was alluding to nicotine. Nicotine does seem to have a lot of good biological effects, but we don't want to encourage smoking. That's what I meant by what I thought was taught on this. And yeah.
Sorry, my question was, I thought if they were related, could you prescribe niacin to stop people feeling an addiction to nicotine because
Yes.
the molecules were related?
Yes.
Yeah.
Most chronic addictive disorders respond to niacin. That goes back to Ulcho and Hofer's papers. And I've actually had a little luck with that because the son of a huge endocrinology practice, the son of the owner, was trying to quit smoking, and he listened to me talk about niacin. I said, look, it can't hurt. Just, do it right, build it up. He quit smoking. He said, definitely the urges were suppressed. I don't really have those kind of issues, but when somebody tells me they get a benefit, I try to substantiate it. And alcoholism, certainly. It seems to help with people that are obsessive compulsive like myself. There's a lot, it does a lot. I'll probably never know everything it does, right, Todd?
Oh, yeah. It's a lifetime, and still you're scratching the surface. But
Yeah.
Gregor, my own take, and I don't know if I'm different here, but my take is that nicotine is really not that bad. It's actually been shown to increase NAD levels in a Nature Family Journal. But of course, too much is, and that with smoking, what's really bad is the 900 other chemicals that come along when you're sucking on a chimney, because the activation and energy and the chemistry, you make just all kinds of weird chemicals. But the nicotine, I mean, I've actually bought the gum to try it because, so I would think if you really want to quit the smoking, maybe you could titrate down with that. And the niacin can help remove a lot of toxins. It helps with all the NAD participates in all of the drug metabolizing enzymes that clear all the toxins and pollutants, for example, from smoking and everything else we've been talking about.
Yeah, yes, niacin does seem to have effect on helping quitting smoking. The other thing I want to mention is there are many ways to boost NAD levels. We mentioned about NAD quite a few times. NAD is one of the very central molecules. I correct myself. I think NAD, when I said was involved in more than half of all biochemical reactions in our body. And we all know about NMN. I want to bring up NMN. NMN is a relatively newer molecule on the market. I guess it's off the market now with the FDA control, whatever. But to me, I looked into detail of NAD, niacin, and niacinamide. So far, the longest history of studies is with niacin, with Dr. Hoffer and other pioneers in the field. With more than 70 years of history. That's number one. Number two is niacin is FDA approved. The approved dosage I mentioned was 500 milligram to 2,000 milligram. And niacin seems to have the full spectrum of biological properties we have seen in helping, for example, the lipids and NAD levels and the other things. Whereas NMN is relatively new. A lot of the benefits we don't know yet. The one common pathway we know is of niacin, NMN, niacinamide, they all lead to boosting NAD levels. There may be other effects we don't know, but this is the common pathway. So to me, we always have to, balance the benefits versus potential risks. To me, niacin, particularly the instant release form, is the one of the cheapest, most affordable, and the longest history of studies, highest safety profile and FDA approval status. So it is my choice in boosting of niacin to boost NAD level, preferable to NAD. Anyway, so that's my take on niacin versus niacinamide, and also NMN. Because some people out there, they just want to. I mean, my concern, like most of us, we're concerned about the health effects rather than the marketing. The money part. Money is important, no question about it, but health comes first.
Yes.
Yes. Yeah. All right. Any other questions? We're about this may shut up by itself. 90 minutes. Well, thank you all for coming to join us, and we look for any other questions, any comments.
I feel honored. I'm on a discussion all about niacin for the most part. I felt like a real hermit or loner for years because nobody wanted to talk about it.
I have one question.
Yes, please.
Stefan from Germany. I would like to know if NAD converts in the process into NAD plus at a later point, because I've read lots of good things about NAD plus.
God?
Yeah, I mean, they always talk about NAD and NADH and the ratio. And there was a debate between Lenny Guarniente and David Sinclair back 8 years ago. I'm sorry, but I still don't understand it very well. I think that the bigger point, though, really is how much NAD, because NAD is rapidly depleted. If you do radiation therapy, it causes DNA damage. An enzyme called PARP comes along and just depletes NAD, and your cell will just die very quick because it can't do anything, can't use any mitochondrial production of ATP because there's just no NAD. Unless you pre-treat them by boosting their NAD, then those cells live. And this is shown in all kinds of stresses. I mean, sugar and toxins and everything. So it's really, I think, the skeletal component of NAD itself that you want to have plenty of, because the stresses will just destroy it. The NAD, NADH stuff is kind of, I think, I don't know, that has something to do with the gradient stuff.
NAD and NADP are convertible to each other now.
So I'm sorry, but I don't know entirely about the NAD plus need versus
thank you.
Having enough NAD.
Plain niacin generates every one of those metabolites. In fact, I try to get a comprehensive diagram. It's bizarre. It almost looks like the MTHFR diagram. It's so many metabolites. And there's things that are required to be present to make sure you get all of them. But it's essentially every molecule you associate with NAD is downstream from niacin. Once it hits the liver, makes the first pass, it's amidated. And there's also the nicotinic pathway in the kidneys, but they're all beneficial, and they're probably all necessary for normal metabolism. But you take the 5 cents a gram niacin, you get a bonus after it passes through the liver. It's all the other metabolites.
Yeah, the only difference that I found, the niacin converting to NAD is a 3-step process compared to NMN, which is a 2-step process, seem to be. But we don't really, I don't know if what a big difference it makes, because ultimately they are all converted to NAD. To me, maybe when you start taking NAD and NMN, there may be a difference in the time required to show effectiveness. But once you start taking them regularly, There shouldn't be any difference, in my view. So NMN, you know, although I have both, because I take niacin every day, I don't remember to take NMN every day.
Yeah, I think the niacin flush pathway, though, it's the only one that really affects the lipids.
Right.
Yes, absolutely.
And also, I think there's a stem cell effect as well. There's a prostaglandin called PGE2 that has been shown to boost stem cells, and niacin massively releases PGE2.
Yeah, niacinamide has not, to my knowledge, niacinamide doesn't show the lipid modulation, modulating
not at all.
effects. Yeah, so that's why niacin still the preferred. Yeah, yeah. Andrea, you have a question?
Yeah, it's for Stephen. I've sent you an email and it's come back twice as undeliverable, that address you've put.
Let me see. It should be, oh, I'm sorry. The little C is missing, Macon. You know, I'm only human. I apologize.
Oh, so it's MCC.
Yeah,
Okay.
I apologize. Oh, I sent that link to Dr. Cheng because I don't know how valid it is, but a guy went to the trouble of measuring NAD in his serum. I don't know what that cost, but he took every form and it was impactful. And I think it might be factual. I'm not certain, but I sent the link to Dr. Cheng. He could share it.
Did you say me?
Pretty cool. Yes. On
Appreciate
on
it,
the
yeah.
chat there.
Sure. Yeah, one other thing I like to do is that whether on the orthomolecular.org website or on the other social media like Twitter or here in video, I like to have more prominent displays of our experts to connect them with our audience to help each other. You know, we can learn and that sort of thing. I know Dr. Pemberthy does provide a consultation service for lipids, I believe, right? And other areas of consultation services. So
Yes,
feel free
thank
to
you.
reach out if you have any more questions. And yeah, that's all we want to hear from all of you, and emails. I apologize because I received a lot of forwarded emails from Mike Stewart, and I haven't been able to answer all of them. Gosh, there's just so much work to do. But that's my intention. We have lots of experts here, and let's use them. Okay, I want to learn from them too. You know, I have only 24 hours a day, and I want to sleep, and I want to eat, and also I want to play badminton. I don't want to work all the time. All right, thank you. I think this is enjoy the rest of the Memorial Day holiday, and we'll finish here. And let us know how we can further improve our services to you and how we can help you. Thank you. And this will be available on YouTube and others. Okay. Well, okay. Bye-bye all.
Thank you.
Thank you.